Good afternoon. I'm going to present to you information about a hot topic these days, that of the solitary pulmonary nodule, which is getting attention not only in the medical press but in the lay press. And what I will do is repeat a lecture that I gave last month not far from here to the fall meeting of the New York State Certified Tumor Registrars Association. The topic is about the solitary pulmonary nodule, which represents very often a diagnostic and a therapeutic challenge. So what are we talking about? Here's a chest x-ray done here at Phelps about a year ago. A gentleman was scheduled to have his hip replacement, and the pre-op chest x-ray, which is still routine, discovered this nodule partly hidden behind the clavicle and superimposed on a rib and marked with the arrow. And you can only appreciate that there's a nodule there when you compare it to the other side where there is none. In this day and age, the next step would be a CAT scan. So the CAT scan shows this nodule much better. Right upper lobe, a spiculated nodule, meaning that the borders are not sharp. You see they send out these tentacles. It's dense and has the radiological appearance of a primary lung cancer. But that's still not proven. And that's what we're talking about. So why should we be concerned when we find a lung nodule, either on a chest x-ray or on a CAT scan? The reason is because in many cases it could be a lung cancer. And so what? Is that a serious problem? It is a huge problem. Just a few sobering statistical numbers about lung cancer. It is the leading cause of cancer-related mortality in this country and in the world. So it's far deadlier than all the other types of cancers that we know: breast, prostate, gastrointestinal, and so on. Almost 250,000 people are diagnosed in this country every year with lung cancer. What you may not know is that the average age of diagnosis is really the 7th decade. People are usually older when we diagnose lung cancer. Unfortunately, almost half of them are at a very advanced stage when the diagnosis is made, which is often beyond curative treatment and allows us only palliative treatment. It's no secret that cigarette smoking is a leading cause for developing lung cancer. And lung cancer really became such a common disease with the advent of smoking. Some patients, however, about 15%, are never smokers. And the question is why, and we'll address that in a moment. Here are some graphs to show you the mortalities from different malignancies, which are from the National Cancer Institute. And you can see this blue line of lung cancer, how it really peaked around 1990, while some of the others remain stable. Prostate, colon, and stomach cancer has come down. This is the incidence of mortality, death rates from a particular malignancy. There's been a drop starting with the 90s, probably related to less smoking, probably related to better early diagnosis and better treatment. This is in men. In women, you can see that it is still higher than breast and all the other cancers that I mentioned before. So it's a serious problem. Let's talk a little bit about a solitary pulmonary nodule. What is it? We define it as a round opacity which is usually well circumscribed and no greater than 3 centimeters. 3 centimeters is sort of a cutoff point between a nodule and a mass. Here's a CAT scan of a mass, much larger, And once it gets beyond the 3 centimeters, the likelihood that it is malignant is about 90%, whereas nodules can be benign. It's nice to see that Stanley Siegelman gets the credit of this definition. When I arrived at Montefiore, Stanley Siegelman was one of the radiologists that we worked with, and he then went on to Johns Hopkins and was a very smart radiologist. Sometimes we first see a problem when it's already a mass, but if we go looking in older chest x-rays, we may find that this mass, which is in 2012 measures 3.5 centimeters, was already present 2 years earlier when it was only 2 centimeters in size. So evidence of growth is important when we try to decide what is this nodule. Here are the 2 corresponding CAT scans of the same patient in November 2010, about 2 centimeters, and you can see it has now grown to almost 4 centimeters in size on the CAT scan. This is a recent patient of ours who ended up getting operated and at this point is doing actually quite well. I wish we had gotten her sooner. Her prognosis would have been better. So what is the differential diagnosis of a solitary pulmonary nodule? A variety of malignant conditions. First and foremost, non-small cell lung cancer. Less frequently, small cell lung cancer. Pulmonary carcinoid, which is a more benign type of malignancy, but still should be considered malignant. Pulmonary lymphoma can sometimes present as a solitary nodule, or a solitary metastasis from another organ, from the bladder, from kidney. These are all malignant. But then there are many benign conditions that show up as a solitary pulmonary nodule. Most common, and we're seeing more and more of these, granulomas, either with evidence of active infection, fungal, or some type of acid fast. There can be benign conglomeration of locally occurring tissue components, creating what we call a hamartoma. It's usually a very rigid nodule, has certain characteristics on X-ray, calcifications that are typical. So if we think a nodule is a hamartoma, we'll tend to just watch it radiologically. And then there are various inflammatory, benign pulmonary nodules, Wegener's granulomatosis, rheumatoid nodules. I've seen patients referred to me worried that they have a lung cancer because they had a peripheral nodule, but the history was one that led me to believe that this could be a pulmonary infarct. And we decided to watch such a patient, and indeed the infarct resolved with time. An abscess can present as a benign pulmonary nodule or active infection of some other type. So the diagnostic challenge that we face whenever we are presented with a radiological diagnosis of a solitary pulmonary nodule is to determine whether it's benign or malignant. And how do we do that? First, we look at the picture. Does the X-ray appearance suggest malignancy or a benign nature? And we won't go into that now, but you can get an idea. Or you can say, I can't tell. Review previous X-rays. Is this nodule there 3 years ago and hasn't changed? Unlikely to be malignant. Or is a nodule there and was smaller and has grown? That is more suspicious of being malignant. So is a nodule new or has it changed is important. Then we look at the whole patient, not just the picture. And we try to determine whether this particular patient falls into a high-risk group for developing lung cancer. And the most important risk factor, obviously, is cigarette smoking. If you look at this pie diagram, 44% of people with lung cancer are current smoker. Another 43% used to smoke, and only 10 to 15% never smoked. I was in France last winter and went into a phone booth, they still exist there, and found a package of Marlboro cigarettes that somebody left behind, and it caught my eye. In letters as big as the Marlboro logo. It says there in French, "Smoking kills." Pure and simple. It's not the general surgeon of the United States has determined that blah, 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 blah. In tiny little letters, you need a magnifying glass to read the message. They tell you what it is. Not that it changes much of the habit. They still smoke a lot in Europe. Now, here is something that you may not want to hear. That there's another risk factor for developing cancer, one which hopefully all of us will have, and that's aging. So the older you get, the risk of developing lung cancer is greater. So, and it's a little different in men and women. So here are age groups, okay? So let's say middle age, right? 40 to 59, the risk of developing lung cancer in a man is 1 in 109. Once you get to 70 and older, it's 1 in 15. So if you have a 25-year-old showing up with a lung nodule, the risk of that being lung cancer is very small. If somebody has a history of prior malignancy, the risk of a new nodule being malignant is greater. Foremost among these are the head and neck cancers. The risk factors are pretty much the same as smoking. So if somebody with a history of laryngeal cancer or any kind of head and neck cancer shows up 5-6 years later with a solitary pulmonary nodule, chances are that 70% of those will be primary lung cancer, not metastatic. But that holds also true with people with other malignancies that are listed here. So a history of prior malignancy raises our antennas as to a nodule being malignant. Patients who have pulmonary diseases other than cancer, pulmonary fibrosis especially, or COPD, are at higher risk of developing lung cancer. Then there are environmental factors. Radon in the home, occupational exposure to asbestos increases the risk of developing cancer, whether you're a smoker or non-smoker. So the risk of developing cancer if you're a cigarette smoker and were a plumber who did a lot of asbestos work in the older days, the risk of a nodule being cancer is high. And there's a list of other environmental factors. And then there are some genetic predispositions to developing cancer. So we've gone through the radiological evaluation, change in size, characteristics, the clinical evaluation of the patient, but that's not where it ends. What we have nowadays is additional tests to help us determine if a nodule is malignant or not. And one that we use practically in every case nowadays is the PET scan. Now what's a PET scan? Well, a CAT scan, as you know, is a radiological image which generates virtual slices through the body. It can do it cutting across like a salami or cutting it across like French bread in different directions, and it gives us a very good view inside the human body. But all it does is show us anatomical details. A PET scan gives you information about the biological behavior of the nodule that we are concerned about. What a PET scan does is it detects areas of increased metabolic activity in the body. Some are normally active. For example, the brain, hopefully. So PET scan of the brain is useless. The heart keeps on pumping. You'll always see it light up on a PET scan. But whether a lung nodule lights up or not is important to help us determine if it's benign or malignant. In addition to telling us if the nodule, that is the center of our attention, is hyperactive metabolically, it will also often tell us if there are other areas that are hypermetabolic. For example, if you have a lung nodule that is hot, and in the colon is another area that's hot, you'd say, maybe this is colon cancer with a solitary met to the lung. So you know where to look. If the nodule in the lung is hot and there is an area in one of the bones that's hot, then you say, well, maybe this is already a metastatic focus from the lung cancer. So the PET scan is very helpful in also screening the rest of the body for increased metabolic activity, which may be related to cancer. But mind you, I keep saying increased metabolic activity. Cancer is not the only thing that has increased metabolic activity. Infection, inflammation, all those things can light up on a PET scan and yet are benign. They're not cancer. So here's an example of a lung nodule picked up in our emergency room along the spine, and a PET scan of the same nodule. You've seen in the side view, right next to the spine, you see the bright yellow spot. Here's a slice very similar to the CAT scan slice, shows the bright yellow spot next to the spine, and looking at it in the coronal view, there it is again. Fortunately, nothing else lights up except there's hyperactivity in the bladder. There's still some in the kidney. So there's a little activity in the liver. All these are normal. You see the two kidneys are lighting up. They're working. They're not taking a break. So there's metabolic activity there, and they light up on the PET scan. So the PET scan is helpful. So now we've done all these things, and we have this nodule, we have the history, we have the examination, we have the PET scan. What do we do next? Do we decide that this nodule looks benign, and we're not sure that it's worth putting the patient through risk of more invasive diagnostic procedures? We may choose to just observe it. And usually observation means repeating the imaging study in about 3 months. Or are we suspicious enough that we want to prove that this is cancer, then we forge ahead in order to obtain a definitive tissue diagnosis? Because without tissue diagnosis, you don't know what you're dealing with. The proof is obviously in the tissue. How do we get it? We can get a sample, a biopsy, either by a bronchoscopy with a transbronchial biopsy of the lesion, endobronchial biopsy if there is an endobronchial mass. We can stick a needle into the mass through the skin in radiology and get tissue. These have advantages that they are minimally invasive, usually outpatient procedures. But the disadvantage is that they are not really guaranteed to give you a sample from where you are aiming to get it. You may miss the target, and they are sometimes come back, the patient is very happy, my biopsy is negative, but we still don't trust it because we don't know whether it is a true negative or a false negative. The more definitive way of knowing what a nodule is to just get the whole nodule out, excise the nodule. Nowadays we do almost 100% of these video-thoracoscopically, minimally invasively, by VATS or a thoracotomy. And sometimes it is the first stage in the OR before proceeding with a definitive treatment. Somebody in whom we highly suspect that it's malignant will go to the OR, will first do a wedge resection, send it to pathology, get a frozen section, get the call back, never soon enough, usually half an hour, and if it is indeed malignant, we proceed with a definitive resection. So it is pretty definitive, but it is more invasive. How do we decide? It's rarely one person's decision. It is usually done based on a consultation between various specialists, pulmonologists, oncologists, radiologists, and surgeons. Again, this is repetitive in a way. We assess what is the risk of cancer in this individual, and we then assess also the risk of proceeding either with the invasive diagnostic, definitive diagnostic procedure or therapy. And not everybody is a candidate for these tests because patients may have other conditions that preclude safe invasion. We go ahead with pulmonary function testing to check for morbidities, coronary artery disease, other conditions that might place a patient in a high-risk category for any invasive procedure. Some of the methods that we use that I mentioned, transbronchial biopsy. This is a flexible bronchoscope. It can be inserted either through the nose or through an endotracheal tube, threaded way out into the lung. This is an image that we see of segmental orifices of the bronchi. They come in different sizes. We can put brushes through these lumina to get tissue cell samples, the biopsy forceps, collect fluid, etc. Last week we did our first EBUS procedure at Phelps. This is a new technology which is based on adding an ultrasound probe to the tip of the flexible bronchoscope. This allows us to see abnormal lymph nodes outside the bronchial tree, either along the trachea or extrabronchial. And under ultrasound guidance, we can push this needle into that node and obtain tissue samples. It's more helpful in staging. Sometimes it's the best way to get tissue diagnosis in somebody in whom we don't have it yet. So this is a new tool in our armamentarium in the diagnosis of lung cancer and other conditions involving mediastinal and bronchial lymph nodes. This is a more advanced technology that we don't have yet, maybe we will one day. This uses a GPS-like system to send a very fine endobronchial catheter way out in the periphery of the lung based on the CAT scan and a virtual map of the bronchial tree to either get samples from the very peripheral nodules or mark it so that we can see it during video thoracoscopic procedures and be sure that we are removing the right thing. Finally, a good way of getting tissue, and we use it quite often, is have our interventional radiologists stick a needle. You can see this white line. That's a needle going right through the skin, right into the nodule, and they get tissue samples which look like this. Doesn't mean much to us, but our pathologists have various histochemical stains that are nowadays pretty accurate in order to tell us whether this sample of tissue is lung cancer and even what type of lung cancer. So this is just a picture of how video thoracoscopy is performed in our operating room. And many of you may recognize Nita, who's on my right hand. And the two of us are looking at each at our own video screen. We see inside the chest. We can put in, here's what a lung nodule looks like. Turns out to be malignant. It pulls the lining, the pleura in. Very typical for small peripheral lung cancer on the fissure of the upper lobe. And this is what an endostapler looks like. When we squeeze this handle, the jaws close. When we squeeze it again, a knife runs from back to front, activating 6 rows of staplers, 3 on each side of the cut, and it cuts in between, leaving 3 rows of staples inside to prevent any air leak or bleeding from the remaining lung. This is what it looks like in the operating room. The stapler has been closed. It's about to be fired. This grasper is holding a little peripheral lung nodule, which turned out to be nothing else but a pulmonary lymph node. Normal, benign. We didn't go in for that. This patient had a lesion in the other lobe. This was just to be sure that this was not a metastasis. This is what a wedge resection with a lung cancer looks like. We cut into the lung and you see the 2 halves of this mass, which turned out to be non-small cell lung cancer. Just very briefly, the histology, as we mentioned before, is divided between non-small cell and small cell lung cancer, which are a minority, and then a bunch of less common types. We now have a new version of our classification, which gives us the staging of every cancer, because the staging is what drives the treatment. If we have a clinical stage that is advanced, many patients either will be non-operable candidates at all, or will require pre-treatment, chemotherapy, radiation. We refer to it as neoadjuvant treatment. Let's talk a little bit about the surgical treatment of lung cancer. Preoperatively, we do our clinical staging, which is based on all the tests that I have mentioned before. We follow national guidelines in terms of what the proper treatment is. We usually use the NCCN guidelines. We review the patient's pulmonary function tests. We get medical clearance and insist on smoke cessation. Not because it's good for your soul, but it's because it's good for the bronchial mucosa. These patients will need good bronchial toilet postoperatively. They'll be losing part of their lung, and they need to be off cigarettes at least for 3 weeks before they can go to surgery. What are the lung resections that we do, depending on where the tumor is, how large it is, and on the anatomy. Here are views of the normal lung, the right one with the 3 lobes, upper, middle, lower, the left lung, upper and lower. And these colors show us the different segments of the lung, which are smaller anatomical divisions. If we have to remove an entire lung, we call it a pneumonectomy. It leaves a patient obviously with less lung to breathe with, so they have to be carefully selected. The gold standard still for treatment of lung cancer is lobectomy, removing an anatomic lobe with all of its draining lymph nodes. But more and more, when we discover nodules early, and we are discovering them early, when they are still small, stage 1, 1A, we tend to go to sublobar resections. There are several ongoing randomized clinical studies to prove that the results of segmental or wedge resections for peripheral small lung cancer are just as good as lobectomy. If you stop for a moment to think breast cancer from the days of radical mastectomy, where the whole chest wall was removed, to a lumpectomy, plus minus radiation, not unlike that. Part of every operation for lung cancer is a mediastinal lymph node dissection. First of all, in order to correctly stage the tumor, if the nodes are positive, the stage is more advanced, indication for post-op chemotherapy, plus minus radiation. Also, there's some data to show that the incidence of recurrence is less when you've done a thorough mediastinal lymph node dissection. VATS versus open thoracotomy, just showing you what the difference is. This marks the incisions that a patient is going to have if we were to do a lobectomy or a sublobar resection thoracoscopically. And this is what it looks like when we do it open. We do not use a retractor when we do VATS resections. Now, some patients are not candidates for surgery. Doesn't mean that we give up on them. We can, on occasion, get decent results with prolonged survival and disease-free survival using either radiation, and these are various modalities, including stereotactic radiation, ablation of the lesion using various forms of energy, whether it's radiofrequency, microwave, or freezing them. Adding to that, obviously, is chemotherapy, which has come a long, long, long way with a whole menu of different chemotherapeutic agents, which are targeted based on genetic analysis of different tumors, and have really made a difference in the treatment of lung cancer. The 5-year survival is still dependent more on the stage at which the cancer was first discovered. And if you are at an early stage, 1A, the 5-year survival is 77%, and it decreases, as you can tell, by stage. As the stage advances, the 5-year survival decreases. Now, somebody is bound to ask, well, what if you don't do anything? Well, believe it or not, there is one paper in the literature from the old Yugoslavia where in a particular area the population thought that they don't trust doctors and they don't trust hospitals and they didn't want to do anything. And people went on to die from their lung cancer without any treatment, and somebody reviewed those cases. The mortality is huge. You know, the average life expectancy of lung cancer untreated is maybe 1 year. So I don't have that exact quote at this time. So what is our challenge? Based on that last slide that I showed you, you'd like to get everybody when they're at stage 1A. How do we find them? we find them not by going on a trip, but by screening. You have to screen a lot of passengers before you find a concealed gun, and we may have to screen a lot of patients before we find a nodule, but the principle is the same. We are familiar with the concept of screening for breast cancer, self-examination, periodic mammograms, colonoscopy, rectal exam for prostate plus minus PSA. The goal is to detect a pathological condition at an early stage before it causes symptoms. Once it causes symptoms, it may be too late. If somebody comes to us because they have rib pain, and that's because of a peripheral lung cancer growing into the chest wall, that's too late. You do not expect any symptoms from somebody with lung cancer at stage 1A or even 2. So we need to detect them at that stage. And the benefit would be improving the chances of curing or controlling the disease. Screening, by definition, should have low risk, should have an acceptable level of sensitivity and specificity. We run the risk of picking up things that wouldn't have hurt you in a million years and start you on a slippery slope of going through a series of tests that may hurt you more than what we're looking at. So it needs obviously careful evaluation of the data. Now, last year, I don't remember if it was around this time, Dr. Lerman presented at this journal club the results that were published in the New England Journal of Medicine of the National Lung Screening Trial. You remember when that was, Gary? Around this time. So it's pretty recent data. And what was that study all about? For many, many years, people were looking to screen for lung cancer. And they used things like sputum cytology. They used things like periodic chest x-rays. And nothing proved to really be beneficial. So it took quite a bit of fighting and persistence on the part of a group of radiologists to get this study off the ground, which involved over 50,000 patients who had two risk factors for having lung cancer. One, they had a history of cigarette smoking of at least 30 pack years. That means either 2 packs a day for 15 years or 1 pack a day for 30 years. And we're in the age group where already there is a higher risk of developing lung cancer. And these patients were randomized to either having a low-dose screening CAT scan or a plain chest x-ray. And they were followed for 3 years. And as you can see in a minute, different things happened depending on what was found. Just briefly, what the bottom line of this study was that those patients that had screening with CAT scans and followed further out had a 20% reduction in death from lung cancer as compared to those that were only screened with chest x-ray. So this pretty much, and the study was stopped at this point because that was one of the endpoints that they defined initially. So most of the patients that were picked up were at an early stage, and it was extrapolated from this data that if this were to be implemented nationwide, we would save about 8,000 lives a year. And this opened up a Pandora's box. You know, there are various societies and associations have put out now guidelines for screening of lung cancer, for lung cancer. It's still an issue of who will pay for it. Always the good old dollar comes into play. And more and more centers are offering screening for high-risk population with CAT scan. Now, sometimes we find on these CAT scan nodules that are less than 8 millimeters. These are tiny sub-centimeter nodules. What do we do with those? I won't bore you with the details, but there are certain algorithms as to how to follow those, because clearly a nodule that we pick up at 2 centimeters at one point must have been 5 millimeters. So the key is how to pick it up when it's early. So in summary, in terms of the screening and what it leads to is we need to find these nodules, and at this point CAT scan is about the only way. And I should actually mention at this point that if I look at my patient population and I see the presenting symptoms as new lung nodule or lung nodule, at this point, since we have not implemented screening, the majority are picked up by chance. They had a CAT scan for an unrelated reason which caught part of the lung. They had an MRI for an unrelated reason that caught the lung and found a nodule. And then it starts the ball rolling and the diagnostic workup. So we spoke about how we find the nodule, what we do in order to determine what it is, and then what we do about it. So to put this whole thing into a structure that hopefully will improve both the diagnosis and the treatment of lung nodules. And again, the goal here is to really pick out those that are malignant, pick out those that are lung cancer, and get those treated early without hurting those who do not have lung cancer. So we put together here at Phelps a lung nodule center, which is a multidisciplinary team. Some of its members are in this room. And we're using all the capabilities that we have here on site at Phelps in order to pick up the nodules early and in order to evaluate and treat them at the state of the art. We have a website which is very simple to remember, lungnodulecenter.org, which goes over a lot of the material that I just discussed today. You're welcome to check it. And I am actually pretty proud of having been able to establish this here in a community hospital. And ever since we started advertising it, we've been getting calls from as far as north of Poughkeepsie and from Connecticut, never mind the local area. And hopefully we'll be able to make a dent in this deadly disease, which is lung cancer. Any questions?
There was a patient who was a smoker, 54 years old, and the choices after all this, is asymptomatic. Chest X-ray, CAT scan, do nothing. The correct answer was do nothing. So how do you, when the society, a distinguished organization, has this quiz and the answer is do nothing, because that's there are so many unnecessary tests, unnecessary ramifications of the finding a nodule which may turn out to be benign, and they are saying do nothing. How do we go to tell an insurer, look, we have this patient and I want to catch this early and I want to do a CAT scan?
Well, okay, there are two issues here. One, what is the medically correct answer? And then the other one, what is the economical side of it? I think it's hard to, I obviously am biased by my experience, which includes many cases over the years of seeing advanced stage 4 lung cancers going through their imaging history and finding that early lung nodule 4 or 5 years ago that was missed. And if the technology that we currently have that can identify a 1 to 3 centimeter nodule is the CAT scan, rarely the chest X-ray. And if a randomized study showed a definite difference in survival in those that were screened with CAT scan as opposed to those who weren't, I find it very hard to deny a CAT scan to somebody who falls into the high-risk group.
The common definition for any of these screening programs is what's the cost per quality year of life saved. And a lot of the discussions in some of the controversial areas recently have, when you add up the cost not only of doing the procedures, but the cost of doing all the things that are done for patients that have false positives, plus the costs and the benefits of keeping people in the workforce or doing other things when you manage to save them. When you add all that stuff up, you come to some number. And the general definition is $100,000 per year of life saved means cost effective. Where that number came from, it's probably old. Inflation has probably raised it a little bit. But a lot of things are surprisingly mysterious or just surprising when you look at what the actual values are. So seatbelts in school buses, sounds like all the kids should have seatbelts in school buses, right? Well, it turns out that the cost per quality year of life saved to prevent kids from being killed in school bus accidents is $2 million. So it's not cost effective, and that's why a lot of school buses don't have seatbelts. But so the question is, where in the spectrum is it when you add up all the fact that a lot of people with small nodules had interventions that the biopsies were negative? You know, most of them go on to have very complicated courses, but they all had at least that.
I see that as the biggest challenge.
Yeah, what was
the biggest challenge is the do no harm challenge. And, but I cannot help but think of the absolute requirement in most institutions for a preoperative chest x-ray before general anesthesia. You know, my daughter who's in her 40s had a simple procedure the other day at Lenox Hill, and we had to jump through hoops because the day before they discovered she did not have a recent chest x-ray. Totally healthy young woman. And that's a given. You try and get somebody into our OR without a chest x-ray. Why is that acceptable? Because it's cheap? Is that it? And does it have a yield? I don't think it has much of a yield. It's just a habit. It's just, you know, it's gotten into our routine, and if you didn't do one and something got picked up, the lawyers would hang you.
And I think that there's probably data that does speak to Salim's dilemma. And even though the college may say, because the data is not totally there yet, so the college may say there's not enough data now to say that you should do it and you should do nothing in that patient, but there's probably a counter-argument. And what happens when the number, I can understand if the number was $5 million per quality year of life saved, you'd say, well, some people, you can't afford to spend society's money on that. If it was $5,000 per quality year of life saved, everybody would do it. What happens when you're at 100,000? What happens when you're at 200,000? What happens at 300,000? Where are you going to make the break? Where are you going to say that it should be covered? Whereas if you want to do it, you can go do it, but you're going to have to pay for it yourself. That's a problem that it's only easy to solve that at the margins. But right in the middle, it's very hard to solve it. And that's why you have to occasionally write a letter to the insurance company saying, well, this is cost effective, it's important in this patient. Or you do something that you really shouldn't do, but you do it to protect your patient because you really believe in the absence of data, is you write down that the patient has a cough. And so you don't.
You start with a chest x-ray, it's unlikely that you won't find something suspicious that requires a follow-up.
The whole point about the studies that started out of Cornell back, right, the first published was that a lot of the stuff they found wasn't on the chest x-ray. And they found a certain percentage of stage 1A lung cancers.
Only 10 to 15% of the nodules turn out to be malignant. Majority are not.
So they did a lot of extra CTs following lesions that didn't change over time. They did a bunch of transthoracic legal aspirations, and they did a few open procedures. And of course, they had to do a few procedures with people had pneumothorax and they actually biopsies. But even there, when she calculated, I recall going to a meeting, it was an ACP meeting, where she presented her data from Cornell, 2005. Yeah. The cost per year of life saved, even with all those complications, was way below 100,000. So she was really believing it, and I think that it probably is low.
We're dealing with the deadliest of all cancer forms that we know of. 220,000 deaths a year from lung cancer, and we know the characteristics of the high-risk population, and clearly data will be forthcoming as more and more people are doing screening.
Gary, do you know what the cost per year of life saved is?
No, I really don't. The other, once you start doing these CAT scans, when do you stop? You do it for 2 years. I mean, this study, 2 years. But if you believe believe in it, you do it for a lifetime. So the cost is, obviously, is going to be...
The radiation is probably causing a few more.
Less than the radiation exposure. I mean, it's a tremendous problem out there to decide what to do with this data.
But also the number needed to treat and correct about 300 or more. The number needed to screen in this case, that particular study was over 300. So that's way a wide score. So pretty.
If you take a high-risk population, we always saw, in my experience, it's 6 or 7 CAT scans at minimum. And in order to measure up the harm that's done by that, like particularly you do a high risk of breast cancer in women who have repeated CAT scans like that.
One CAT scan is equivalent to how many X-rays, Chester? 300.
Well, but that's a regular CT.
Right, but we do a low-dose CT, which is...
Especially a single breath hold is even less.
The threshold is equal to 3 X-ray.
Yeah.
So,
if the bronchoscopy and transbronchial tissue sampling can give you most often some questionable results, why not proceed to VATS to begin?
Very often we do. That's why we discuss, if I have a case, I'll go to the pulmonologist and say, what do you think your likelihood is that you are going to get this with the bronchoscope? And they say, and if you got a negative result, would you trust it, and so on. Very often we go ahead to the VATS because it is still really a very minimal invasive procedure. If it comes back benign, patients are usually out in 24, 48 hours with 2 or 3 little holes between the ribs, and it's definitive. And you have tissue for cultures and so on. If it's a granuloma, you're right, we often will do that. But we really, the nice thing is to be able to work with colleagues jointly where nobody is pushing for their particular method of diagnosis. We really try to do what's right for the patient, and every patient is different.